Good morning, everyone from San Francisco here in the United States. Good afternoon in Cameroon, and good evening to our friends in Asia. Today we have an esteemed guest speaker. Very delighted to have Dr. Martha Gulati. She serves as an academic chief of cardiology for the University of Arizona College of Medicine in Phoenix. She completed her medical school at the University of Toronto, Canada, and her residency in cardiology fellowship at the University of Chicago. She is a fellow of the American College of Cardiology and the American Heart Association. Dr. Gulati is passionate about the study of women and heart disease, as well as about its prevention. As a principal investigator of the St. James Women Take Heart Project, a study examining cardiac risk factors in women, she's helped to set new standards for women's fitness levels and heart rate response to exercise in women. In addition, she's also co-investigator on the Women Ischemic Syndrome Evaluation Study and serves as a co-investigation for the Women's Health Initiative. She has, of course, won multiple awards and is a well-renowned faculty in this space. So we are extremely delighted to have her as our guest speaker today. Health for the World. Thank you all for joining, and I will let you take it away, Martha. Thank you.
Well, thank you for having me here today. And I was tasked with talking about primary prevention of cardiovascular disease. I am really hoping I can make this not so American-centric. So I hope that, you know, maybe if it becomes like that, certainly ask me questions. But some of primary prevention is something that worldwide we all care about, and I will show you why. So I have no disclosures. And here's just the numbers, just so that you understand why we all over the world care about heart disease. There are 422 million people with cardiovascular disease on our last assessment worldwide. Of course, it varies by country, but this is a huge number of people living with cardiovascular disease. And there's about 18 million people who die every year. In fact, about a third of the deaths globally are due to cardiovascular disease. Now, 85% of all cardiovascular disease is due to either heart attacks or strokes. And in general today, I'm going to keep focused on that, on ischemia, atherosclerosis. I'm not going to talk about rheumatic heart disease and other forms of cardiovascular disease because, you know, our preventive efforts are really focused along heart attacks and strokes. Now, it is important, since this is a global audience here, is that 75% of cardiovascular deaths actually occur in either low-income or middle-income countries. So there's definitely been a change in the demographics. As communicable diseases have gone down, what we're dying of, especially in low-income and middle-income countries, is cardiovascular disease. We made better strides in the Western world, but we have many other issues. And of course, right now, we're living in a pandemic. So of course, now we're watching communicable diseases actually rise. So take this with a little bit of grain of salt. But what are the numbers? So I already gave you some of them, but as I already said, heart disease is the #1 killer globally, and it accounts for a third of the deaths in the world. The great thing about cardiovascular disease is much of it is preventable, and that's why we're going to talk about cardiovascular disease prevention today, because if over 80% of deaths are preventable, we're just not doing what we need to do for patients. Now, globally, cardiovascular disease is on the rise, and the reason for this is because we have a growth in population in much of the world, and so that affects the numbers. Now, geographically, things differ. As I already said, low and middle income countries have a disproportionate share of cardiovascular disease. And you can see this here, what is changing. So high income countries, it's shown in red is always heart disease for my purposes, but you can see for high income countries, we've had a reduction in cardiovascular disease, and we're more likely to die from cancers. And this blue bar is all cancers altogether. We don't generally do that, but just for the purposes today, I don't want to break it down, because as you can see for middle income and low income countries, you can see that cardiovascular disease has the disproportionate share of deaths. So ischemic heart disease is what I'm going to try to talk about more. When I'm talking about atherosclerosis, we're generally talking about heart attacks or symptoms of angina, which goes on to either heart disease in some format. And again, the highest rates currently are in Central Asia and Eastern Europe. So there's always geographical distributions, but for health loss globally, it is ischemic heart disease that contributes the most. Now, when we're talking about prevention, there's three types of prevention. There's primordial prevention, primary prevention, and secondary prevention. Primordial prevention is things that we can put in place at a public health level or before any disease or risk factor exists. Things that, just to give you an example, is if we put in smoking cessation bans, as we have done in public spaces or in restaurants in some parts of the world, including here, we have been able to see a reduction of cardiovascular disease. If we improve fetal health or we improve infant health, we may reduce their risk in the future of developing cardiovascular disease. If we reduce globally pollution, will reduce cardiovascular disease in the population. And that's really what primordial prevention is. When you have cardiovascular disease, we're talking about secondary prevention, meaning you already have the disease. How do I keep you alive? How do I prevent a second event? But what we're going to talk about today is primary prevention. So you may have risk factors or you're at risk. And how can we address these risk factors to lower your future risk of developing cardiovascular disease? So that's what we're going to talk about. But it's important to understand that obviously to take care of cardiovascular disease, we need to be involved in all of these: primordial, primary, and secondary prevention. The way that we talk about primary prevention, at least in the United States, is we talk about the ABCs. And it's just an easy way to remember it, right? ABC for the prevention of cardiovascular disease. And I'm going to go through all of these in detail, but the first A stands for assessing risk. It also stands for aspirin. And we'll talk about both and whether, the role of aspirin has become a little less strong. So that's why it had to share space with assessing risk. Blood pressure. Controlling blood pressure is our next step. Controlling cholesterol, helping people quit smoking or prevent them from smoking altogether. Encouraging a healthy diet and healthy weight, and controlling diabetes is your D's, and E is for exercise. So it's the ABCs, but it's really the ABCDEs. It's just not as catchy to say all that. So now in that, we talk about shared decision making, which means making the patient part of the partnership and knowing what's important to them and what we can do together. There's obviously a team-based approach. It isn't always on the physician. It may be you may have nurses involved, you may have dietitians involved, and we'll talk a little bit about that. And that we also, whenever we talk about that, we also have to talk about the economic and social factors, because it's fine to prescribe something, but if someone can't afford the medication, they're not going to take it. So again, there's certain things that they care about or have a certain value system, it's also going to affect what they do and not do. And it's important to know that in advance so that you both have realistic expectations. And by both, I mean the patient and the physician. So when we talk about the patient-centered approach, we always want to take into account a team-based approach, but also shared decision-making, as I said, should be the best way to guide strategies to reduce cardiovascular risk. Additionally, the social determinants of health, as I said, that's a class 1 recommendation. We talk about classes of recommendations, and they really range from 1 is you should do, and 3 means you shouldn't do, and 2 means we have limited evidence. difference, but these are all class 1 recommendations. And so they're very important and part of our strategy for prevention. So let's go to the first one, to assess risk, the A. So assessing risk, we all do use different risk scores. In Europe, they use the SCORE methodology. In the United States, we use the ASCVD risk score. I think for you know, our risk score tends to be, it's been validated in white people and also in Black people, but not so much in other races. Europe, the way they use a score is distribution by countries, and that, so it's representing more of a Caucasian population. So in general, you know, if your country has already created a risk score, but really these are the two predominant risk scores that we have, and we just, with those limitations, we use them. What you can do with those risk score, though, is help assess either their short-term risk, which could be their 10-year risk, which is what the ASCVD risk score gives us, or you can assess their lifetime risk. And both of them are important, but I'd say for a young person, I tend to talk more about lifetime risk because they tend to come out as low short-term risk. And then for older people, you might want to focus a little bit more on their short-term risk because, you know, because of their age, and they may already look at high risk, and you need to address the here and now versus addressing it in the future. So that's how we assess risk. This is just, I wanted to show you, it comes as an app, but it's really hard to show an app because you have to enter everything individually. But just to show you, this is what we use in the United States, the ASCVD risk score. You put in the age, you put in their sex, you put in their race. And like I said, really, when you put in other, it defaults as white, even though, quite honestly, people of other races, like South Asians, don't fit in any of these. They're a high-risk group, as I'll get to and talk about, but we just don't have good risk scores built for other races. But we have validated, as I said, in white and Black Americans. Now, blood pressure, you put in their systolic and diastolic blood pressure, you put in their cholesterol, their HDL, and their LDL. You know if they're diabetic, if they're smokers or not, and whether they're on treatment. And once you put that in, it's going to give you a short-term risk and a lifetime risk. Now, for younger people, so you can see here, it really works for people aged 20 to 79. But if you're under 40, it won't give you a short-term risk. It'll just give you the lifetime risk. So because automatically everybody who's young, age is such a driving factor to your risk that their risk always tends to be low. You almost don't have to calculate the risk. Now, what you do, though, in those younger people and in people who have a lower risk is make sure they don't have any risk enhancers. And what are risk enhancers? These are things that increase people's risk for cardiovascular disease. And we'll go through them a little bit, but in more detail later. But just to quickly point out, things like having a family history where people in your family die at young ages, or if you have chronic kidney disease. And then there's some conditions unique to women, things like things that happen in pregnancy that can only happen to women, like preeclampsia or premature menopause, gestational diabetes. Those are things that are specific to women, and we take those into account. Chronic inflammatory conditions like rheumatoid arthritis and lupus is important. Things like HIV are important because they accelerate the risk for heart disease. And in fact, more people in the US who have HIV, they don't die from HIV anymore, they're dying from heart disease. Ethnicity matters. So South Asian ancestry, really, this is a group of people that are at exceptionally high risk in the United States. In a lot of countries where they've sort of had a diaspora, there's just been a greater risk of cardiovascular disease. Other biomarkers also are important. If you have those can help you. But these things are things you don't need to do tests for. You can just ask their history and help you decide if they're a higher risk person. So when we assess risk, as I said, these are our level of 1 recommendation is to assess risk in people aged 40 to 75. But if you're under the age of 40, at least assess the individual risk factors every 4 to 6 years. I say every 5 years. And unless something changes, if there's something where, they've gained weight, you might want to check it sooner. If they report to you their diet is bad or they stopped exercising, you might want to assess it sooner. And so, these risk enhancers are so important. And so what do you need to know, just so that when people say I have a family history of heart disease, if they say that to me and they telling me about a grandfather or a father who died at the age of 80, that's not really early heart disease. But when we consider it premature is when there's a first-degree male relative, meaning a brother or a father who dies before the age of 55, if they're male, or before the age of 65, if they're female. That's what I need to know, because then that's early cardiovascular disease. And that's exactly how I ask it and on every patient. Knowing if they have a genetic disorder where they make excess cholesterol. So these are people who generally run around with very elevated LDLs, and that is a different group. And so those are people that we automatically consider higher risk. If they have the metabolic syndrome, and I'm guessing most of you know what the metabolic syndrome is, but I always say if you don't, think of the person where their tummy walks in the room before the rest of them does. That's metabolic syndrome. It's where they carry their weight in the center, and that puts them at higher risk for triglycerides, higher risk for blood pressure, higher risk for diabetes. And so, we use their waist circumference and also a low HDL to make that diagnosis. If they have 3 of them, they have metabolic syndrome. Chronic kidney disease is a risk factor for cardiovascular disease, so it's important to note that as well. And the inflammatory conditions that I already chatted about. Again, these sex-specific risk factors, race and ethnicity matter, and biomarkers, if you have them, will help. Now, women, I will tell you, like, I was hoping I could just talk to you about women and cardiovascular disease, and maybe I'll get invited back to do that. That's really what I do. I only see women now, maybe because I feel that they're dying disproportionately from cardiovascular disease. And we're identifying unique risk factors in women. And actually, more than just what I said, I just wanted to show you a paper we wrote where we talked about our younger women, what are things that put them at risk, and they only happen in women because they're related to our hormonal status. Things like early or late menarche put women at risk. If they're on oral contraceptives, or if they have polycystic ovarian syndrome, if they undergo premature menopause or primary ovarian insufficiency, that puts younger women at risk. Things during pregnancy, things like gestational diabetes, gestational hypertension, preeclampsia, or preterm delivery, delivering a child before 37 weeks. Even fertility therapy, although it's kind of a mixed bag, it may not increase long-term risk, but it certainly increases the risk of hypertension during pregnancy. And then for our older women, thinking about menopause and hormone replacement therapy, certainly like timing of menopause actually matters as well. And if they're on hormone replacement therapy, we certainly need to know that when we're risk stratifying them or if we're diagnosing them with heart disease. So antiplatelet therapy, I'm not going to get into this too much. I'm sure you might get a talk on this somewhere else, but aspirin therapy, we used to prescribe it a lot more, but more of the data has shown that it increases risk in primary prevention in the sense that it causes more bleeding. So the benefits of aspirin therapy are generally quite limited. Certainly there's individuals who will benefit from aspirin, but that's a decision between the doctor and the patient. And nowadays we are not recommending age cutoffs to start everybody on aspirin. So blood pressure is one of the most important risk factors that we all need to be aware of and be on top of. Hypertension contributes significantly to ASCVD morbidity and mortality. ASCVD stands for atherosclerotic cardiovascular disease, if I didn't say that already. And there's lots of things we can do for hypertension. Many of them are non-pharmacologic. Some people will need pharmacologic treatment though. And really, we've changed changed our threshold for hypertension in the United States. We've made it basically that, you know, normal blood pressure is when it's less than 120/80. And so you should know that. Certainly hypertension worldwide is a major issue. More than 6 million people have hypertension worldwide. It makes it the 4th ranking form of cardiovascular disease, causes for disability, life years lost. Now, this is US data, but I wanted to show it to you just to make my point about how important hypertension is. You can see in the purple and green, these are people without hypertension. Female are purple, men are green, and it's stratified by age. You can see the red and blue, red women, blue is men. Those are people with hypertension though. And you can see if you don't have hypertension, the risk of cardiovascular disease is much lower. Hypertension tends to be driving it at all the ages. So it's really important to understand that the risk for heart attacks and stroke is so closely linked to hypertension. And we need to do a better job of treating blood pressure in our patients in order to reduce the risk. So this is just, again, from our guidelines, you know, that there's things about lifestyle, which are non-pharmacologic interventions that we can do and we should be doing on everyone. The minute we diagnose hypertension, we should be talking about weight loss, a heart-healthy diet pattern. The DASH diet is what we recommend, sodium reduction or salt reduction. Increasing potassium in your diet, not supplementation, meaning not taking a pill, but rather eating food that is rich in potassium. Increasing physical activity is certainly part of it, and limiting alcohol. I know everybody wants to hear that alcohol is good for the heart, but it's not good for the heart, especially related to hypertension. Certainly moderate alcohol consumption may be beneficial, but really for when they have hypertension, they really need to reduce their alcohol intake if they want a non-pharmacologic way to reduce their blood pressure. Certainly, you know, when their blood pressure is above 130 systolic or above 80 diastolic, we do recommend medications if they're high risk, and if they're not high risk, we may wait for their blood pressure to be a bit higher, above 140/90. So here you can just see sort of what's outlined in all those tables is here. If they have normal blood pressure, meaning a blood pressure under 120/80, everybody prescribe lifestyle to them. Everyone needs it because it's a lifetime exposure to hypertension that matters. So if you can keep them with low blood pressure, they may never need pharmacologic therapy. Now, if they have elevated blood pressure, which we define as 120 to 129 systolic, then you can use non-pharmacologic therapies. That's a class 1 indication to just work on lifestyle. But if they're high risk, you want to add in the pharmacologic therapy. And once they're above 140/90, they'll need both non-pharmacologic as well as blood pressure lowering medications. But to emphasize lifestyle, these are the things that we have evidence for that can change blood pressure without any medication. So for example, weight loss. A 1 kilogram weight loss can cause about a 1 millimeter mercury reduction in systolic blood pressure. And in intervention trials where people lost weight, including the DASH study, we saw around a 5 millimeter reduction in those who had hypertension just by weight loss. And if they were normotensive, they got a little less benefit. And certainly that would be, but you get more bang for your buck for somebody who already has hypertension. If they adhere to the DASH diet, the diet alone, which was rich in fruits and vegetables, whole grains and low-fat dairy products, and the fruits and vegetables that they recommended were high in potassium. And this was a true intervention trial. They saw in hypertensives a systolic drop of 11 millimeters of mercury. That's as good or better than any one medication alone. And it was less good for those people who had normal blood pressure, but it certainly wasn't negligible. Reducing sodium intake lowers blood pressure, again, most in hypertensives. Increasing potassium in your diet through a dietary rich of potassium lowered the systolic blood pressure 4 to 5 millimeters in those who had hypertension and about 2 millimeters in those who were normotensive. Physical activity, strong evidence as well, and that includes both aerobic exercise and dynamic or isometric, resistance training. All of it can lower blood pressure. So it's really important for us to recommend that, because patients will always ask you, I don't like medications, what else can I do? So give them this as a prescription. Choose one of these to add into them and have them come back if they're not going to be compliant. Diet's the hardest one, but even supplementing with potassium-rich foods can be enough maybe for them to avoid medications, or at least to limit them to one medication. Alcohol consumption, as I already told you, lowers systolic blood pressure as well, and should be part of any recommendation. Now, the C is for cholesterol. We talk a lot about cholesterol. I know it's a talk into itself. We really focus in the United States and around the world on LDL cholesterol lowering, and it's important for people in general. It's important for people with diabetes, and of course, it's important for people who already have cardiovascular disease. But it is a first-line treatment, and especially when people have very elevated cholesterol just to begin with, you will automatically consider statin therapy. And these are level 1 recommendations, and lots of them are based on risk. I'm not going to, again, you don't have to remember these things unless you're, working and using our recommendations. But again, we use the risk score to determine who would benefit most. If they're diabetic, at a minimum, they need a moderate intensity statin. And if they're higher risk, they'll need a high intensity statin. If they already have an LDL above 190, we recommend statin therapy, because those are people who we consider probably genetically abnormal cholesterol formation, maybe a heterozygous FH or even homozygous FH, sometimes get identified that way. The other C is for cigarette smoking, and this is reducing in the United States and Canada dramatically. We really have made huge headway in smoking reduction, although now our new problem is vaping or electronic cigarettes, which I think worldwide is becoming more normal. I'm not going to really get into e-cigarettes except to say that we don't really have safety data, and the data is a little mixed. It can actually cause heart disease. Well, has an association with endothelial dysfunction that may contribute to formation of cardiovascular disease. So I don't consider vaping or e-cigarettes benign, but in the low and middle income countries, there's still a lot of cigarette smoking. And so at every visit, we should be assessing whether people smoke or not and helping them quit. So, it's one thing to say you should quit. Of course, they should quit and they know they should quit, but it is much harder for them to quit. It's an addiction. At that point, it's an addiction. I'm sure many of them would love to quit, but how can we help them? So this is the conversation that needs to happen. Are you ready to quit? Do you want to quit? What have you tried? What haven't you tried? And coming up with a way to help them. All of these nicotine replacement therapies are definitely useful, and there is pharmacotherapies as well. And for some people, it's just quitting cold turkey, but not always successful. So I apologize for that. So you should assess this at every visit, and we consider that a class 1 recommendation. And, it should be asked at every visit. And even if they quit smoking, ask it when they come back, because often people who quit often can go back to it. So you can use a combination of behavioral interventions or pharmacotherapy. Both of them together actually increase the likelihood of them quitting. And ultimately, if they're able to quit tobacco, they'll lower the risk of cardiovascular disease. And the other thing that we are really concerned about is secondhand smoke exposure. And that's how we made public health policies where people can't smoke in public places, but also that risk is very clear to that we need to reduce exposures to reduce cardiovascular risk. So it's not enough that just the person quits, but if the individual doesn't even smoke, asking them about secondhand smoking exposure. So again, just know the pharmacotherapy, whatever you have available is important to know how to prescribe it and advise, because this is what your patients want it and they want it from you. They really are not, they're going to need a partner in this, and usually that a trusted physician is the person that helps them actually quit. So all those medications are important to know about. All right, diabetes is the D, and for adults with type 2 diabetes, certainly there's again a role of lifestyle changes as well as medical management. We have new drugs. I've just been the last 4 days, including today, up at 2 a.m. in the morning to listen to the European Society of Cardiology that was delivered virtually. And we're so excited about these new medications, these SGLT2 inhibitors that are out that will actually be game changers, and not even just in diabetics. But I do understand in many parts of the world, these new drugs take a long time to get there. And it would be better if we could prevent diabetes altogether, but certainly treating it with the medications available is important. And diet can really improve glycemic control. So don't minimize that. Same with exercise, that improves glycemic control. So these are things that aren't, don't really cost, well, certainly the exercise doesn't cost anything. A good diet does cost, so I don't want to minimize that, because it's certainly sometimes easier to get fast food than it is to get fresh fruits and vegetables, so I don't want to minimize that effect. But for people with diabetes, again, you can see from our in green the class 1 recommendations. Everyone, we recommend heart healthy diet, exercise, treat other risk factors, and then treat, of course, the diabetes if they need it, starting with metformin, which is cheaper than some of the new drugs. And the newer drugs are down below here as a 2B recommendation, but I do think that they will increase with time. All right, so the other D is for diet and weight. And certainly, the diet, we've talked already a bit about how important diet is for so many things: hypertension, cholesterol, diabetes. So, but even if you don't have any of those things, diet and weight are so interconnected. I always say you can't outrun a bad diet, because there's people who exercise and then they still have excess weight. And, that's because they likely eat too much. Certainly, we recommend that you get more protein from either plants or from animals, but animal be lean protein and fish, rather than the higher fat, the higher saturated fat that exists in red meat or processed meats. We also recommend staying away from refined carbohydrates and sweetened beverages, which certainly increase the risk of diabetes and elevate triglycerides, etc. And then, of course, we need, for adults that are overweight or obese, to counsel them on weight loss, which, again, we're not very good at this as physicians. We just say lose weight, but we don't always equip our patients with the tools to lose weight. So now obesity is a growing problem, literally. I mean, you can see here countries and their obesity problem. Of course, the United States, they're number one. I'm not sure that they should be happy about that, but they are. They have the highest obesity rates in the world. And actually countries that in low income and middle income, but low income especially, we don't see as much, but it is a growing problem. As I said, people are living longer. communicable diseases until recently were not as big of an issue. And then our dietary and globalization of the world has really changed. Like fast food is everywhere. You know, French fries are everywhere. I think you can travel anywhere in the world and get French fries. And so, I mean, these are our diet, our accessibility, our exercise patterns are changing. We sit a lot in front of computers like you and I all are. And this is a big problem. So, and you can see it doesn't matter though, it really eats into our healthcare. And I'll tell you, we'll see these numbers actually grow as obesity continues to grow. But also I will say that COVID-19, this pandemic we're all living in, has actually affected disproportionately people who were obese. And so my suspicion is that these numbers will grow even more if we look at the year 2020 by itself. So it is going to be a very interesting thing. We're realizing just how impactful having cardiovascular disease and risk factors are during COVID-19, because even though it isn't necessarily that they are getting heart disease, they're certainly getting COVID-19 at a greater rate, and then they may end up with cardiovascular complications as a result. So it's a level 1 recommendation for everyone to, you know, work on weight loss and give them counseling and diets and calorie restrictions to help them maintain their ideal weight or to achieve their ideal weight. And this is really important to talk about. I also highly recommend, I know it's a 2A recommendation here, is to measure waist circumference, because that can tell you about the metabolic syndrome. And I think it's really where you carry your weight almost more so. And we have different numbers for different parts of the world, because often in countries, like developing countries like India, for example, they will have very low body mass index, but they carry their excess weight in the center. We're seeing they're much more predisposed to the development of diabetes. So we, you know, and that really is preceded by the metabolic syndrome. We recommend a diet that, again, high in vegetables and fruits, legumes, nuts, whole grains, and fish, and trying to reduce saturated fats and reducing the cholesterol and also the sodium. So, and certainly we don't recommend any trans fats, which are often in the deep fried and processed foods, because that accelerates cardiovascular risk. So exercise is the E, and we recommend, as does much of the world, that adults should engage in at least 150 minutes of exercise per week if they do moderate intensity exercise, and 75 minutes a week if they do more vigorous exercise. I generally recommend to my patients that they should do 30 minutes every day and not take any days off of exercise, because I think if it's a habit, they're more likely to do it. We do have it as a level 1 recommendation to engage in a physically active lifestyle, to do the minutes that I already described. And sedentary behavior, even if you exercise, can increase cardiovascular disease. So we are getting concerned. I get concerned the more I sit at my desk, which lately during COVID-19, I've been sitting at my desk way too much. The way to ask about exercise is I take it as a vital sign. I actually ask them what kind of exercise do they do every day, and I estimate the number of METs that is. I want them to try to do more, I want them to do more vigorous or moderate exercise. So trying to figure that out may just be asking, what do you do? Light activity is things like housework. And sitting, of course, you get 1 MET for that, but that's really not exercise. Watching TV is not exercising. But if you are doing more vigorous, if you're running, if you're swimming, if you play tennis, if you go biking, even some people who dance, they dance pretty vigorously, and that may be considered a more vigorous activity. But at least moderate activity is what we're aiming for. Things like yoga, walking, biking, all of that is really important. But the problem for many of us is the fact that we actually spend a big portion of our day doing nothing. So we might do our exercise, you know, for 20, 30 minutes a day, hopefully maybe more. But then you know, we might move around or walk places, and we used to walk a lot more in the hospital, and now we really sit a lot at our desks. I'm not sure if it's changed in your countries, but we're really minimizing our exposure to patients, and so only those people on the wards are seeing the patients. Then we have, obviously we all need sleep, which is great if we can get it, but then we have a lot of hours that we sit. And in North America, at least, a lot of those hours are spent in front of the television and spent in front of the computer. So all of that, you know, playing video games, this is getting more and more concerning because we only give a little bit of our day to active exercise. So we really need to start changing that. Now, the other E, in addition to exercise, is consideration of the economic or social factors, sort of the social determinants of health that I touched on at the beginning. And these are things that we need to take into account with any of our patients, because we must remember where we're born, where we grow, where we live, where we work, you know, who we are ultimately impacts our health and well-being, and our accessibility to medication, but also our accessibility to safe places to walk, healthcare, you know, employment, etc. All of this matters. And this is the part where, when we're in front of our patient, we know that these things impact. Why don't you take your medications? The usual answer for many of my patients is, I can't afford them. And then we try to work on, how can we get the medications for free? What can we do to help? Can we give them the lowest cost medication? If you don't know that, you may not respond right to them. You may not understand why they don't follow their blood sugar, but if they can't afford the strips to check their blood sugar, they're not going to. I have patients that save their insulin or their drugs, use them every other day because they can't afford them. And so they think it's okay to do it, you know, to split it up in that way. And so we have long talks about how these drugs work and why they need to be done every day, and the harm that they might be putting themselves at. But the realities of their life is ultimately impacts how they can actually take care of themselves. So, you know, that it really does matter. And these social determinants of health are becoming more and more discussed. In fact, I think in the past we didn't really talk about them, but now they're entering our guidelines, as this specific guideline that I'm sharing with you has, but actually many of our other guidelines, it matters. Certainly, they need this as the basis of their pyramid of all things. You know, all the other things may change. We may have good guidelines. We may have good community policies. We may have information. But if they don't have some stability in terms of the things that they need to take care of themselves, it'll all come falling down. So these things are things that we actually recommend in everything. If they come for their cardiovascular risk, we need to be talking about their health literacy, or they may not understand what you are even prescribing to them. And one of the simple ways you can do that is simply by talking to your patient, asking them to repeat what you recommended at the end of your recommendation. So if you're saying, take this one blood pressure medication every day in the morning, you want them to repeat that back so that they understand, and you can't skip days, and here's why. Like, you know, you just need to have that conversation with them. Certainly assessing also for psychological stressors is something we should be doing a better job of. It is our job because it affects their overall health. Diet, asking about diet is one thing, making recommendations is another, but knowing what they can adhere to is even another. Again, there's vulnerable populations in our society, and usually it's the people who have lower income, who have the worst health, but also have less access to good food. And that happens in the United States all the time. We call them food deserts, because sometimes you'll live in a certain neighborhood where you really have just a local grocery store and they sell very few fresh fruits and vegetables. And so this is really something that we've got to change. It may be just a problem of the United States, but I imagine it's a problem all over the world. Exercise, again, we can prescribe exercise, but if they can't exercise outside of their house because of safety reasons, then that's a problem. Certainly weight loss, again, talking about that is one thing, helping them and giving them a way to lose weight, and the counseling matters. And these things matter for everything. Smoking, high blood pressure, diabetes, all of it matters. So somebody wrote an editorial a couple of years ago, and I've seen this written in a few ways, but I just like this figure, is that, you know, we need all of these for optimal cardiovascular health in our society. And we started with this at the beginning, the primordial prevention, then the primary prevention, and the secondary or tertiary prevention. So we need to be able to do all of these and changing the conversation. But we invest, most of our countries invest most of our money on once people already have disease, once they already have cardiovascular disease. We definitely spend less in the prevention, in the primary prevention arm, often because patients don't know, or we don't have good screening systems. And we spend even less on these more public health type issues or primordial prevention, where we can have more impact on our society if, for example, you cut out diet soda or didn't make it available, or you taxed it so that people would drink less of it. So these are things that we need to do more of, but right now most of our world spends money on disease. So, you know, it costs far less to do these primordial prevention, but it's hard to tell a country that it'll be the long-term gains. You know, right now it's the short term where they have to invest money. So in conclusion, I just want you to not forget your ABCs and your Ds and Es when you're working on primary prevention in patients. And remember, this is a worldwide issue. This is everyone's issue, is prevention of cardiovascular disease, because we're all seeing it more and more, and people are dying, more likely to die from cardiovascular disease. So this is a quick discussion. Sorry, I went a little bit over. I wanted to give you about 15 minutes for questions, but and I'm not sure, should I pull the chat room up to be able to see the questions, or are we just gonna unmute it, or how does that work, Elliot?
Usually we'll transition to see if there are any questions from Cameroon, and then we'll go to any questions in the chat box. But thank you so much, Dr. Gulati, for that presentation.
Oh, you're welcome.
And so are there any questions from Cameroon?
I think they're on mute if somebody's talking.
Good morning. Good morning there. It's like she's not listening.
I can hear you.
Okay. Good morning. So my question is with regards to cholesterol. So what's your take? What do you think about elderly patients who usually have comorbidities, 65 years, usually have comorbidities, and if their cardiovascular risk is more than 10%, if their 10-year is high and they need high intensity statins, what do you think, considering the fact that they are at risk of the side effects of the statins? Do you think we still have to put them on very high doses of statins if they need that? Or considering maybe the side effects, we might go down?
That's a really good question. You know, and in fact, at the European Society of Cardiology, there was a debate on that very topic. So that's very insightful of you to ask. If they have cardiovascular disease, so if they already have cardiovascular disease, the answer is yes to statins. But from a primary prevention standpoint, we do not have enough data on the people that are over the age of 75 about what we should be doing. And that's really where you start having the shared decision making. You tell them we don't have the data, and if they have more side effects from taking on it taking it, probably you don't need to give them that medication. You know, still advise them the lifestyle things, maybe lower the statin if you think they're too high risk and see if that reduces the side effects. But the data is not strong. Most of our trials, we did not enroll people over the age of 75. The small amount of data, I think from all HAT study, we do have people over the age of 75 there, but it did not come out significant for those people that were above the age of 75, in the sense that we did not necessarily get more better outcomes. And additionally, when you look at the amount of time, I think that the amount of time is about 6 months that you might get them from taking a statin. If their quality of life is really bad, like they have muscle aches and they can't walk, I would rather them have a good quality of life than just buying them 6 extra months of taking this medication but having no really good quality of life. So I am definitely more about what is the evidence and what what are we getting from starting a medication in someone like that. And I will say, I think you said if it was a woman, and for women we have even less data, because we really didn't enroll enough women in general in primary prevention trials. And then especially the elderly women get excluded from a lot of the trials.
Okay, thank you.
Good morning. So my own question is about nicotine. So the usual dose I use for nicotine is 4 milligrams, but I saw 2 milligrams. So which one is more of, which one do you prefer? Because our starting dose here is usually 4 milligrams to chew when they have the urge to smoke.
I'm sorry, I couldn't hear you at the first part of the question.
So I'm saying that in your presentation, I saw that you could use 2 milligrams of nicotine, but the gum that we have is 4 milligrams. So I'm saying, is there any difference in starting with 4 or starting with 2?
Are you talking about statins? I'm sorry, I'm still...
Nicotine, the nicotine gum.
Nicotine, sorry.
So I saw there was a dose of 2 and a dose of 4. Is there any preference?
Well, you have to use what you have. And I think you just have to work with the doses that you have available. So I don't think there's going to be a big difference. I don't know if I can say that based on trial data, but you use what you have.
Thank you, Dr. Gulati. Hello? Can you hear me?
I can hear you.
Okay, yeah, thank you very much. This is a very important talk for us. Like you mentioned, cardiovascular disease is a huge problem in sub-Saharan Africa. It is growing. It's amazing the number of people we see with cardiovascular disease, diabetes, hypertension, and who are coming down with complications of all these diseases. Actually, our system, the Cameroon Baptist Convention Health Services, runs a huge NCD program. We're dealing with diabetes patients and hypertension patients, and we're seeing a lot of them where we're trying to help them in a good number of ways. So this is something that's really very significant and important for us. It is a growing problem in our country, and I think in sub-Saharan Africa as a whole, like you mentioned. I think that one of the interesting things I found was the fact that you can confirm that aspirin is not totally off the table, because there were some studies that had come at some point, and we had talked about this in the residency program. I'm glad that you can confirm that aspirin is not totally off the table. One of the problems we have in our setting is that we do not have any validated risk scoring systems, but I think we're still using the ASCVD, the American system, which you projected. That is what we are using in our environment. So I'm just wondering sometimes if we should just extrapolate all that information and use in our own setting. Well, that is what we are doing. I don't know how effective that is. but that is what we are doing. You said it's been validated in whites and I think black, maybe Americans, things like, I don't know that there are any validated systems among or done in Africans per se. So I think that might be a problem for us. So I had a question about the D component of the ABCD spectrum. Diabetes, you talked about, I'm just wondering how we should we be very radical in treatment of patients with pre-diabetes as a means of prevention of cardiovascular disease? Well, not established pre-diabetes.
Yeah, pre-diabetes, I mean, you know, so I always say metabolic syndrome is like pre-diabetes. If they're not diabetic yet, they're going to be if we don't do something. And a lot of that, even for metabolic syndrome, when you identify metabolic syndrome, you're just saying that they have a cluster of these risk factors that increase their risk for heart disease. That's the time, at least, to start addressing everything: diet, blood pressure, cholesterol, and their sugars. Simply by improving their diet, you might prevent them from going on and being diabetic. Once you have diabetes, I think that's the most catastrophic thing, because it's really hard at that point. Once you have diabetes, in my mind, you pretty much have cardiovascular disease. So we need to be more proactive. Certainly, it'd be great to prevent them from becoming pre-diabetic, but if you identify them as pre-diabetic, that's the time to really act. And I agree with you, so to your other comment about aspirin. Aspirin, it isn't off the table, but it isn't really on the table as much anymore. If they're high risk, you may want to give them aspirin, but just remember the bleeding risk is greater for many patients, and you really need to know, is the benefit you're going to get greater than the risk of bleeding? And asking about prior bleeds and knowing if you're, going to cause problems with that medication. The other point you made about the ASCVD risk score, I think, of course, ideally every country would have their own risk calculator. We're at a loss. I don't think ours is perfect. The ASCVD risk score, I already told you, doesn't include so many people, including myself. I'm not included in that risk score because my ancestry I'm an other. So it doesn't come up as anything. And ideally, every country would create their own, but not every country has their own. We just don't have those kind of population studies yet on other ethnicities. And, we're learning a lot, and you don't want to categorize people as Asian alone, that everyone in Asia is the same. Probably not the same even in Africa, to say everybody in Africa is the same. There's a distribution. So we need to know, but I think that ours, since we share some commonalities just from a Black descent, I bet you the ASCVD risk score is the right one. At least it's not perfect, I would say, for people from Africa, but it isn't the worst. I think that if you use the European system, that would probably be less accurate, because if you think of the demographics of Europe, it probably has even less representation. Ours has been well validated in our US Black population, but I would agree it's not perfect. And I have a lot of patients who are from Africa, and they're not what we call African American, like they weren't born there. They've come from Africa and immigrated, and they're very different than people who have been multiple generations historically from Africa many generations ago. So it's not perfect is what I'm trying to say. But if you don't like it, I would just assess individual risks, each of the risk factors, use it that way and start addressing it that way. It's just a way for us to talk to our patients sometimes nicely to say, your 10-year risk is this, especially when it's high. You have a 20% chance, or you say to them, you have a 1 in 5 chance in the next 10 years of having a heart attack. That hits home in a different way.
He does. Thank you. Thank you very much.
Welcome.
Thank you, Dr. Gulati, for answering that question. And again, thank you so much for your presentation and your willingness and your time and your expertise today. We sincerely appreciate it.
Oh, it's my pleasure. Thanks all for having me.
Okay, and with that, we will conclude our webinar. Again, thank you everyone for coming.